Good afternoon. I'm Linda Baker, the Learning Director at the Center for Research and Education on Violence Against Women and Children. On behalf of our Learning Network and Knowledge Hub team, I would like to welcome everyone to our webinar today, Providing Disability-Affirmative Care, Deconstructing Ableism in Trauma Support. Please think about the traditional lands you are currently situated on and join us in acknowledging and thanking the generations of Indigenous peoples who have cared for these lands and in celebrating the continued strength and spirit of Indigenous peoples. The ongoing work to make the promise of truth and reconciliation real in our communities, and in particular, to bring justice for murdered and missing Indigenous women and girls across the country should inform our discussions in this webinar and beyond. Today's presentation will be 1 hour long, followed by up to 30 minutes for questions and answers. Please type up any questions or comments that you may have for our speaker in the Q&A box at the bottom of your screen. Near the end, we'll present your questions to our speaker for her response. Earlier today, a link to the presentation slides was emailed to you, and that link is now in the chat box. The presentation will be recorded, thanks to our presenter, and available on our website within the next few days. Now, I'm honored to introduce our speaker. Dr. Kaylee Rosen is a clinical and health psychologist working at the Toronto Psychology Clinic. As a disabled woman, she offers anti-oppressive, disability-affirmative psychotherapy to adolescents, adults, and couples. Her scholarly work combines traditional clinical health psychology with critical disability approaches to explore the experiences of trauma, social and psychological embodiment, body image, and eating disorders in disabled women. During the pandemic, Dr. Rosen has been very busy and entertained by her 3-year-old daughter, and we're delighted that she's made time to be with us today. And with that, Dr. Rosen, I'm going to turn it over to you. Welcome.
Thank you. Thank you for having me. I'm really excited to be here today. And I always find it a little bit funny to do presentations without seeing my audience. So I'll have to just pretend you're all laughing at my jokes and go from there. Okay. So here's a brief outline of what I'm going to be talking about today. I'm going to give you a little bit more background into why I'm interested in this topic and how I've come to kind of study this and also like really practice it in my day-to-day therapy. And then I'd like to jump right into like, what is ableism? Why is it so damaging to individuals, disabled individuals who need support, whether it be for trauma, for abuse, for other things, mental health. It's very pervasive in our society, and so much so that sometimes we don't even realize what we're doing and how we're doing it. So I'd like to kind of open that discussion while acknowledging that there's still lots to learn as we go along. I'm going to give you a bit of a background about trauma and abuse in disabled persons, with the caveat that there's not a ton of research done in this area, unfortunately, and we'll talk a little bit about why that is and how ableism actually contributes to the research as well. And finally, I want to leave you with less so tools about how to navigate ableism and more so like, how do you question your own lens about how you see the world? Because most of the ableism that we experience, we don't even realize we're putting it out there. We don't realize that it is out there because it's, as I said, it's so pervasive and surrounds everything that we do. So I want to give you tools in the sense of like having you understand the world a little bit better, understand other people a little bit better, so that you can continue to kind of grow in this area and know what you didn't know before. I'd like to talk a little bit more about who I am, how I got into this area of work. So as mentioned in the bio, I am a disabled woman. I developed my disability later in life, and I'm from a very small town in Ontario. So if anyone's heard of Pembroke, Ontario, we have about 15,000 people. And as a disabled person, I was one of the only disabled women going to my high school. I didn't know a lot of people with disabilities. So, I mean, I think I myself came from a very ableist and narrow background, even though I am a disabled person myself. It wasn't until I really moved to Toronto and I started meeting other really cool disabled people and made friends with them, became involved more in advocacy, that I came to realize that there's other ways to view disability that are different from how I was trained as a psychologist or how I was treated as a person going through the medical system. So although my disability is quite visible, I use a wheelchair, so that immediately signals to other people that, yes, I'm disabled. There's also lots of different other types of disability that aren't visible. And I want to make sure that we talk about those things as well, with the caveat that, like, as a visibly disabled person, my experience is going to be grounded mostly in that of physical, visible disability. That being said, disability is quite complicated. So as I've aged, I've also started developing non-visible disabilities, including chronic pain. And that's been kind of difficult to navigate as a person who's figured out how to navigate my visible disability and advocated for that, and now has to also negotiate how do I identify this new part of my identity that maybe is a new form of ableism that I didn't even understand before, and I don't know how to negotiate it in the same way. And as I age, I anticipate like other things come up too. And there's lots of friends and family members in my life who have non-visible disabilities, visible disabilities. And it's all that complicated web of how we exist in the world and how we are humans and how we have to navigate social systems that don't accommodate different types of ways of being, different types of bodies. I have a picture here of me and my daughter. This is Gwendolyn. She is wearing a t-shirt that says, "Ask me about my feminist agenda." And I just put that in there because I think that also becoming a mother has become a very interesting way of navigating ableism in the world, and how now I have to navigate, it's almost like I thought I had it figured out, and then I became a mom and I had all these other ways in which I had to navigate the world as a mom with a disability who doesn't often get, disabled moms don't often have the same rights as moms without disabilities because there's not a ton of us out there. And I think that, like, as I also want to model to my daughter how important it is to continue to challenge ourselves, continue to work towards making the world a better place, challenging social systems, not taking on that blame yourself and feeling like, well, the reason why I can't get a job is because I'm not good enough at what I do, rather than like understanding what are the systems in place that keep us down and keep us challenged. I also wanted to give a little caveat that, as I mentioned before, I do struggle with chronic pain, and my body was not so participating when I did this presentation as I would like it to be, which is often the case. So I encourage you, if you notice any strange typos, to take them as acts of resistance in an ableist society rather than just simple typos. Language use. Language is so personal, and it's always changing, it's fluid. And I'm sure as people notice, language in the disability community is changing constantly and changes from one person to the other and over time. So that all to say, we're going to talk more about language in this presentation, but I wanted to say that in this presentation, I do mostly try to come from identity first language. So you hear me say a disabled person as opposed to woman with disability. That being said, I was taught in a very traditional way, as I'm sure a lot of you were who are listening today, in that we use often person first language, have the person before the disability saying, so person with disability. And it wasn't until I was kind of exposed to activist groups that I realized that there's other ways to view disability, and I prefer myself to use identity first language because it signifies to other people that there's nothing wrong with being disabled, and like it's a problem that the world doesn't accept disability. So I have a quote here from a participant in a study that says, "To me, person first language demeans the person. It attempts to dissociate them from some characteristic, and in so doing, defines that characteristic as bad by virtue of it being necessary to dissociate from." So the same way you wouldn't say like a person with queerness or a person with blackness, like I wouldn't say person with disability. And again, as I say, sometimes I still do say that because a lot of people still do prefer it. And I do tend to respect other people's opinions of how they want to identify. And, you know, I can't just totally switch from one to the other. So you'll hear me say both probably today, although my preference is identity first. Just to also say intersectionality is really important as well. We are not just one identity. We are often, you know, many identities, and we can be oppressed on all or some of those identities differently. So although I'll be focusing on disability today, I just want to really acknowledge that like gender and race and sexual orientation, all those things also impact how we are treated in society. And it's important when we're talking about a person that we consider all of those identities as much as possible. So I have a quote here by Sonia Renee Taylor, who's amazing if you ever want to read her book. Our beliefs about bodies are disproportionately impacted. Those who race, gender, sexual orientation, ability, and age deviate from our default notions. The further we are from the default, the greater the impact. But we are all affected, but not equally. So what is disability? I'd like, this is usually a part in the presentation where I get some participant feedback and people to kind of like shout out what are some images or thoughts or words that come to mind immediately when you think of disability. What I'm going to do is I'm just going to kind of share what people have told me in the past. And if you wanted to kind of join in the chat too, that would be great. But for instance, a lot of people, when I ask this question, the first thing that comes to mind is a very visual blue symbol of a wheelchair. Wheelchairs have come to be associated with disability by virtue of our society that when you see this, you might think if you're a non-disabled person, you might think, oh, that's the symbol of where I can't park. I see it and think, oh, this is for me, this is my access. This is the way I need to get into the building. Some people see it, have negative associations, others more positive. But it's very simplistic, and often our medical way of viewing disability focuses only on like, what can the person not do? How do they deviate from what's normal? And oftentimes we think of like temporary things. So for example, this picture here is someone who has broken their leg, and we see that as like something that will be fixed soon. And when it is fixed, then the person can kind of resume normal activity. And so often the medical system doesn't know quite what to do with us people that don't follow that same pathway. So you'll see lots of examples of disabled kids, and we'll talk about that a bit more, how when they're younger, they get kind of put into programs to help them become quote unquote more normal or more functional or more whatever word you want to use. And sometimes it actually doesn't relate as much to function as it does to normality. There's a participant in my research study for my dissertation who got an arm prosthesis when she was a baby, 6 months old, so that she could look quote unquote more normal, but it actually hampered her ability to crawl. So in some ways it's like, who does this benefit and why does this exist? On the other side of the spectrum, we also have disability being represented in our society as people who are almost superhuman. So you'll see the Paralympians or these amazing athletes or like Terry Fox figures who do these amazing feats that you couldn't even imagine doing. Although this is like a very positive way to see disability, it also has a lot of problems because it creates another way of othering or separating a person from kind of like the diversity of normalness, whatever we want to call it. Yeah, they're seen as other. It's so amazing that you couldn't possibly ever be like them. In the disability community, we have an expression called inspiration porn. So this is an example of inspiration porn. You see a little boy, he's running, he has leg prosthesis, and it says across it, your excuse is invalid. So we don't know anything about this little child, I should say. I'm assuming their gender, but I don't know what it is. We don't know anything about this child except that they have these prostheses, and we're assuming based on that entire thing that their life is horrible, and if they can run, then like, why can't you run, right? So it's another way of putting disabled people on a pedestal that almost makes them separate or othered. Here's another example. Never ignore someone with a disability. You don't realize how much they can inspire you. So, I mean, you might have seen these, you might have shared them too. Like, that's, you know, this is why we're here learning about this. And it's kind of like a nice message, but at the same time, like, who is this person? You know, maybe they don't want to talk to someone. Maybe they're just out on the beach. You know, how it really takes away the complexity of the person by kind of putting them in a position where all they are is there to serve another person who maybe feels bad about their life and needs a pick-me-up. In our society, we have, you know, grown up with these opposite views of disability. So on one hand, you have the Tiny Tim character, sweet, angelic, asexual, would never hurt anybody, is there pretty much the only reason for that character is to support the main character and help them work through difficulties of consciousness, or, you know, help them become a better person because this poor child needs their support. On the other side, we also have the Captain Hook character, which is a very angry and bitter and evil character that has let their disability take over and make them into this horrible person who just basically wants to take everybody else down. Interestingly, like, these dualities, even though they seem extreme, they're very relevant, and you can see them even now in our society where, you know, you have the telephone kids who are like the Tiny Tims of our society, and we kind of like are forced to be in those positions because our systems aren't set up to support families who have people with disabilities in them. So people are often forced to like ask for funds, ask for money, go towards charity. And, you know, nobody wants to give money to Captain Hook. So you have to kind of act this role of being like this grateful, innocent person in order to get the things you need in life. You'll see disabled adults that I work with, and they carry that through them throughout their life when they're interacting with medical professionals, and they're trying so hard not to show any negative emotion, any anger, anything that would put them in a category of being disruptive or bitter or difficult to work with, so that they can get what they need. And it's actually really hard to come out of that, and it takes a lot of kind of like unlearning in therapy to learn that it's okay to feel angry, it's okay to feel sad sometimes, without someone being like, oh no, their disability has taken over their life and now they're sad. And then on the other hand, I can also see people going to the other direction, because I don't know how many people are here from Toronto, but like taking the TTC every day when I used to go to work before COVID, it was tough to be polite all the time and be like, excuse me, you need you to move. I could see myself eventually just being like, God, like I gotta get onto the train, move out of the way, like, and you start to become almost put in that position, because if you express any type of anger, people characterize you as being bitter and upset with the world. So I just want to say one more thing about the disability stereotypes, because they're so important, and we all grew up with this, and they shape how we treat disabled people, and they shape how we view disability. And it's impossible to separate that out and see people as like real, complex, messy humans without challenging how we've learned about disability in our lifetime. So I want to talk a little bit about, in the next slide, about disabled women and why this is relevant. Disabled women experience a lot more disability-related violence and gender-related violence. So you probably are familiar with, violence against women, and disability-related violence kind of adds a new element of another, what am I trying to say, risk factor that impacts women. So they're at an increased risk for abuse. So as I mentioned, there's not a ton of research out there, but some studies have suggested that 4 times more likely to experience sexual abuse than women without disabilities. Intimate partner violence is a big contributor to that. And we'll talk a little bit more about why that is. And trauma. So we know that the risk for PTSD is elevated in disabled women. But interestingly, like the way we look at trauma in, as a psychologist from the DSM, Diagnostic and Statistical Manual, which is how we diagnose PTSD, it's very specific. So trauma has to be related to some sort of traditionally understood threat to one's life, or seeing somebody else's life in threat. However, there's a lot of trauma that goes unnoticed, and you'll see me use the word trauma a lot in this presentation, because I'm seeing it as like the traumas that people have gone through that have impacted their life today and how they navigate the world and have kind of like left its place on them. So for instance, having a really difficult repeated medical trauma by seeing doctors and going through painful experiences is traumatic. I don't know if it would traditionally fall into a PTSD diagnosis. So that's just really important to keep in mind, that a person doesn't have PTSD to experience trauma and to have it impact their life. The other population that has been more studied in this area is those with developmental disabilities. So the risk for assault is 4 to 10 times higher in persons with developmental disabilities. And they have something that is really important to consider, which is like institutional trauma. So in our society, we have a history of institutionalizing disabled people when they're younger. That was kind of seen as like the better option for them to get care. However, as we're seeing, especially during COVID, these institutions don't necessarily have the person's best interest at heart who are living there. They can be more like warehouses, right? Where trying to save some money or not having enough support staff or just being isolated from the community has a huge impact. And it can impact a person's autonomy, their dignity of care, how they determine what kind of care they get. They can have limited advocates with them if they can't communicate for themselves. Not a lot of options. So you might just be like, well, you can do this or you can not eat, right? For example, or you can have a shower at this time, or you're not showering for 2 weeks. And there's lots of different reasons why these institutions don't work, but it's really speaks to long-term impact of like devaluing disabled lives as well as like elderly lives and other people. I wanted to also mention before I move on that like I specifically talked about disabled women because that's where most of the research is. However, I think it's safe to assume that disabled persons who are trans or non-binary would also have a heightened risk for abuse and trauma, if not even more so because of their additional identities. We know that disabled people also have an increased risk in research for things like depression, anxiety, eating disorders, which is my area, and addictions. There's probably more to talk about as well, but I think it's important at least when we look at the literature, limited it is, we do see an increased risk. But why is that? Well, we need to consider really the whole picture. So disabled people exist on multiple axes of social marginalization, not just because of their disability, but because of other things, as we talked about before. But some disability-specific ones might include poverty. We know that disabled people are chronically underemployed. So one stat that I recall that really hits home for me is that like disabled people are often highly qualified in that they have the educational background, but then can't get hired. So they're an underemployed resource. And I think that really speaks to the fact that like college and universities do accommodate better than the workforce does, unfortunately. So they do have like accommodations. If you can get to university, like I know there's issues with that as well with cost and such, but then they go out into the workforce and they can't get hired for a lot of different reasons. Housing issues. So finding specialized housing in the city is a nightmare. There's like 5-year wait lists just to get an accessible apartment in some cases that are accessible and affordable. Transportation, put a picture here of a wheel-trans bus. So I'm from Toronto, so I'm talking more from that, but every city usually has some sort of, I don't know what the correct term is, but basically kind of like a special bus that, quote unquote, that is used separately for persons, disabled persons. And often it's because the traditional transportation system is not accessible. So if you can't access the subway, you can't get on normal buses, or you can't sit outside in the snow and wait for a bus to come pick you up, then you have to rely on this system. And let me tell you, it's not a very good system. So often you have to know way in advance when you want to ride. You have to book your rides. Often you're spent waiting hours upon hours just to get your ride somewhere. If you go out to go to the bathroom and you miss your ride, you've missed your ride forever. And it's very stressful. And I think that as people providing support, it's important to be aware of these things, because, if you tell someone, my appointment for you is at 11 a.m. and the person shows up at 11:15 and you're like, I'm sorry, I can't see you. I mean, that's pretty harsh when they probably aren't responsible for the bus being late or not showing up at all, or, you know, sometimes I have to book the bus an hour in advance and I'm still late. So it's quite challenging. As well as how much does this person have access to their community, access to supports, access to other supports that might help people with dealing with these mental health issues. One thing I really want you to come away with this presentation remembering is that living in a world that's inaccessible, and by inaccessible, I mean in a lot of different ways, not just like building a ramp, but also how is your chronic pain accommodated? Are there breaks? How is your, if someone has ADHD, how are they accommodated if they can never show up on time for appointments, et cetera, et cetera, et cetera. That creates trauma responses in both marginalized and disabled people. So I think that, you know, just sit with that for a second. Hasn't been a lot of research in this area, but it's really important when I look at like even like the qualitative studies that I've done, where interviewing disabled people and them talking about what it's like to navigate these systems, what it's like to take a chance on a new therapist and then show up and have that therapist be really say something horrible to them about their disability, or assume that their disability is this, or just be completely clueless about disability, and then them just feeling totally discouraged and not wanting to go out and see anyone again. So although it's a challenge for us as support providers, because sometimes when a disabled person comes to your door or signs up for a video appointment, you don't know how much crap they've dealt with in the past and how much trauma they've dealt with, of always getting shuffled around, of always being rejected, of being put down because of their disability. And you, as the support person, have to, if they get to you in the first place, have to then help them, support them in a way that is affirming. So again, as I just mentioned, people in my study would talk about avoiding getting support, becoming depressed because they're just like so defeated and hopeless after seeing yet another person who doesn't understand, having panic attacks, you know, navigating the system where they need to find housing, or they need to find funding, for example. They can't afford their next wheelchair, so they're just gonna like drive their other one into the ground, and that causes a lot of stress and anxiety. So as probably a lot of us are aware, the trauma-informed approach helps us to reconceptualize common responses you might see in someone and understand them from this perspective, rather than assuming that there's something wrong with this person or there's something wrong with their character. So I'm sure we've all heard of like the fight, flight, freeze response that people get when they feel threatened. So for example, hypervigilance. I know a friend who was hospitalized because of a mental health issue, and became hypervigilant about access needs, because a hospital is a scary place when you're disabled often. So they would be like looking around for, how can I go to the washroom? When am I going to go to the washroom? And I mean, it would be characterized for them as this person's having a manic episode, and, you know, they're just manic about their access needs. But when really you have to take a step back and be like, well, if you couldn't go to the washroom, would you be not stressed out about that? You know, would you not be freaking out? If your whole life you've been told your body is not welcome, or we're not going to accommodate you, then suddenly you're in the hospital and you're like, oh no, it's happening again. And somebody says to you, oh no, they're just manic. You know, imagine how dismissing that is. Emotional arousal, yeah, like if you're upset, if you've been in this place before, I can't imagine you're not going to be calmly kind of talking through it when you kind of realize, oh no, it's happening again. I might not get the support I need. I might not get I might not be able to get my basic care needs met. right? It's scary. For a lot of people, the emotional numbing or blocking becomes a survival strategy, right? I don't want to get overwhelmed and have a panic attack at the doctor's office. So what do? I block it out. How does that look? Well, that can look in a lot of different ways to people. It can look like, I've seen with my clients, excessive people pleasing. So they have a hard time getting angry. They have a hard time expressing assertive, healthy anger to people when they've wronged them. They have a hard time saying no. They have a hard time being honest, right? So I know as a support person too, I've been there where you're just like, why don't you tell me if you're not happy with the service I'm providing? Like, I want to change, I want to help you. And that's terrifying for a lot of people, and they don't want to share that. And it's coming from a trauma response. Masking, this is a term specifically, I think it's used in a lot of communities, but I know it's specifically for the autistic community, where they were taught, especially autistic people growing up, perhaps going through like ABA therapy, trying to make them, not have these autistic characteristics that set them apart. And they learn to mask those by pushing them away, acting quote unquote normal. If they have something like stimming, for example, that like helps them relax, they'll not do that in public so that people accept them and don't stare at them and don't treat them differently. But it has a psychological impact, right? So constantly pushing away things that reassure you, make you feel safe, help you express your whole gamut of emotions has a huge emotional impact, where like suddenly the emotions do come out and they're big and they're strong, and they might impact the person's life in a negative way. So that also looks as like passing as normal. And you'll see that across all disabilities, where even people with a very visible disability might try to hide the fact that their feet are swollen by pushing their feet into like really tiny shoes, and that has a really negative impact on their health too. Or I don't want people to know that I go to the washroom in a different way, so I'm just gonna like pee and hold my urine all day and get a bladder infection. So like this is all things that we need to be kind of like aware of. And I'm sure no one will be surprised by this, but disabled people are underutilizing preventative healthcare services, while at the same time they're shown as overusing the medical system. And I think that's really speaks volumes, because they're not getting preventative healthcare services that they probably need, such as things that prevent these emergencies, and then they end up in the emergency room kind of like needing a lot of care by that point. So there's not a lot of like services that provide really barrier-free, accessible care specifically for disabled people. I find a lot of organizations try to integrate it. Sometimes they do a good job, sometimes they don't. Sometimes it's tough for them because they don't have the resources. And it can become really challenging. And that also goes for mental health services, right? So even myself as a psychologist, trying to find a job in the city, trying to find an office space that was accessible for my wheelchair to work at was almost impossible. I'm really glad I found, working at the Toronto Psychology Clinic, they were so accommodating and great and working with me, but like, it was really tough for a while to find a place that, most people, they just find an office space in Toronto, they can't afford a lot, so they book it. And unfortunately, like there's not enough demand for disabled people to make that a priority for a lot of practitioners, even though it should be. And the reason it's probably not in demand is because people have learned that there's nowhere for them to go, so they don't go. They're less likely to be identified as needing support, and less likely to be identified in things like research, healthcare, prevention programs. Again, if you're having trouble accessing the community, accessing support services, getting out of your home, you're not going to be included in the research. You're not going to come into the prevention programs. You're going to end up being kind of like missed in a lot of ways. shelters, and which I know a lot of people listening today are working at, like shelters or other support services for women women or other people, trans people, probably men too, who've experienced abuse and trauma. And that's a challenging one because, I mean, I can tell you right now, like if I had to leave an abusive household right now, like I don't know where I would go. I need the amount of support care that I need. I don't think a shelter would have that. And even if they did, I wouldn't believe it they would, so I probably wouldn't go. So for instance, maybe your place is accessible for wheelchairs. Maybe the bathroom's even accessible, but do you have attendants who can support a person who needs physical assistance with, daily activities? Do you have a lift that can lift someone out of their wheelchair and help them into bed? Do you have translators who can work with a deaf woman who that's her only way of communication is through ASL? Do you have a safe space for autistic folks who, can't be in a room with all these people at once, for example? I want to talk a little bit about caregiver abuse because this is really common with disabled people. So we know that 60% of people experience, the rates are 2.1 times higher for disabled people to experience abuse by family members, caregivers, and medical professionals. And it's something that often doesn't get talked about because there's often not a whole lot other options. And it's sad to say, but like I experience this a lot in a lot of the groups I'm a part of, where someone's like, my family is abusing me, I need to get out, I can't stand this anymore. And there's nowhere for them to go. And it's really sad. And another option would be like a nursing home, and that also is not great, right? So caregiver abuse can look like preventing the person to have basic needs and assisted devices. So saying to them, okay, well, you can't go to the washroom at this time and this time because I need to do this, or punishing them and saying, well, fine, if you're going to be mad at me, I'm not going to help you to the bathroom, or I'm not going to, give you your wheelchair. In my study, I found that it was actually quite normalized, this type of abuse, and so much so that even as a person who was doing the study, and I am a disabled person, I didn't recognize it as abusive. I saw it as normal. So my participants were talking about things like their caregivers telling them that they needed to lose weight so that they could lift them. And if they weren't going to lose weight, they weren't going to come see them. And I was like, oh yeah, that's normal. And it wasn't until someone else, another disabled woman, came to my presentation and was like, what about abuse and trauma? And I was like, oh no, nobody had abuse and trauma in my presentation, in my study. And I realized that like, it was my own biases that wasn't seeing it. So this is just a cartoon to kind of show that, we have all these systems in place that we think a person can complain if they're getting abused, or they can complain about their healthcare provider. But often, the options are, you can complain about your service provider that's coming home. Well, what are you going to get next? There's nothing else out there. So it's kind of like the hook is like dragging the person back into like institutionalized services, which is a real problem. Medical trauma, I mentioned this before, but I just want to kind of talk about, for a lot of, I'm focusing on physical disability right now, but this happens across all disabilities. In one study with Carla Rice, she talked about how her participants described medical trauma as the same way a sexual abuse survivor would describe sexual abuse. So it was so invasive and dehumanizing. And there was an ongoing challenge of bodily autonomy. Even in my own study, people would talk about, the doctors would just come in and kind of like poke and prod them, even as like young women, pre-puberty, and like all these residents would come in and nobody would ask them, nobody would talk to them. They would talk to them as if they weren't there. So having consent and talking to the person and talking through your procedures is so important. I just want to mention that, like, when I started psychology, I probably, like a lot of people, I was like, I want to help people. I'm disabled and I want to help other disabled people. And it wasn't until I like really got exposed to the disability community that I was like shocked at how psychology and other disciplines are kind of viewed in like the critical disability community. So here's a quote by Goodley and Latham that describes mainstream psychology as pathologizing, voyeuristic, individualized, impairment-obsessed discipline that has contributed to the exclusion of people with impairments. And that was something that I had to work through. It was like, how do I still be a psychologist, but like also not be a part of this? Because I don't want to be a part of this. I have some poll questions that I just wanted to send out. So if Sarah wouldn't mind sending the first one out. I want to ask what kind of, what did you learn about disability in your own training, if you are a healthcare professional or support person? So if you would just let me know yes or no, did you learn about it? All right, so about 62% say yes, which is probably what I expected as well. And now I want to ask a more specific question, which is, did you learn about the social model of disability when you were training? Okay, so a little less here. So now we've got 71% saying no, I did not learn about that. And same with me, I didn't learn about that either. I was kind of surprised about it. The last question is, did you learn about ableism at all in your training, in a meaningful way, about how do you navigate ableism, for instance? Okay, so 65% say they have not talked about ableism in their training. So thank you. I just wanted to kind of get an idea of, if things are shifting. And I know when I went to school, there wasn't any talk of it at all. So I'm curious. I'm going to show you one video, which is I recently got into TikTok, which was probably a mistake. But anyways, it was a really good video about the impact of therapists. Oh, maybe it won't work. I'm just gonna see if I can play this here. No. I'm going to just keep going in the slides and try to do it at the end because I'm afraid that I'm going to miss something here. Let me just go back. So when we look at ableism and people who come for counseling, they often describe feeling really misunderstood. And they talk about an overemphasis on physical impairments while simultaneously ignoring social why a person might be disabled. So there might be an assumption like, oh, you can't walk, that's really sad, while not looking at like, well, why is that sad? Maybe it was because they can't go to the party they want to go to on the weekend. There was also an overemphasis on stage theories in early psychology. So things like either the person was in depression and denial, or they're super inspirational and cheerful. So stage theories can kind of like look like a person moving through like these grief stages almost. But you know, if you were born with your disability, what is there to grieve really? So it doesn't really capture the most people's experience with disability. And you get back to those emotional stereotyping that we talked about at the beginning, which is like either you're depressed and bitter or you're super happy and cheerful. And these are all things that cause barriers to treatment. There can be also assumptions about a person's character. So your ADHD client who keeps missing appointments, are we going to assume they're just not motivated for therapy, or, you know, is there something else going on? And it's easy to make kind of value judgments about disability when you're not seeing them as being like socially impacted by their disability. And then what does accessing support even look like? Can a person get there? Is it affordable? Is it accessible? Is your practice intersectional? Most of my experiences have been with people who are really well intentioned, but kind of oblivious about disability. So as for instance, I'll meet with someone like a social worker and be like, can you help me get funding for this? And they're just like, yeah, like, but I don't know where to look. And so I end up like giving them a lot of, well, this resource exists and that resource, because I've had to navigate the system. So I'm aware of all these different ways in which a person can get funding or get support that often people are not even aware of. Like I can't imagine, I can't tell you a number of times I've had people say to me things like, what do you mean all the subway isn't accessible? Like, I thought it was. Like, what do you mean? It should be accessible. Like, you should write a letter. And it's like, well, yeah, like if that worked, I would have done that. And it probably, like, it's safe to assume the disabled person probably has advocated a lot, and, you know, they're not going to change the entire system with a letter. That doesn't mean, if you don't know something, it doesn't mean that you can, it doesn't mean that you're always going to fail as a provider though. I know I had one experience with someone who recommended me to a clinic, and I said, well, I'm sure they're not going to accommodate me. Like, they don't have lifts, which are like Hoyer lifts, which are things that most clinics won't have. And the person said, well, I'm sure they do. And I said, well, you know, I don't think they do. And she said, well, why don't you leave it with me? And sure enough, she went out and she called every single clinic for me. And, you know, I ended up being right. They didn't have any lifts, but I really appreciated that. Like, I appreciated that she was like, hey, I'm willing to like do the labor for you this time. You don't have to go home and call 15 people and be rejected like you always are. And, you know, it's not your fault that you're oblivious. Like, I'm oblivious too in a lot of ways, because these are really friggin' complex systems. How do you navigate funding? Attendant care support, it's quite complicated. You know, there's temporary support from CCAC in Ontario, but then there's also direct funding models, and then there's also agency models, and there's nursing homes, and there's supportive housing, and they all have their own rules, they all have their own wait lists, and they all have rules that change. So you used to be able to get CCAC when I was a kid, you know, anytime if you were disabled. Now you have to have like something wrong with you that's immediate and it's temporary. Mental health support, same thing. You know, where do these people exist? There's not really like a lobby of disability aware therapists that we can just draw upon. I mean, there should be, but like it hasn't been created yet. The transportation systems, as I mentioned, are quite complicated. Developmental services, which is something I don't know as much about, but like DSO and how do you get funding for support workers, general accessibility, so things that you need to know about, like masks for COVID for people that need translation. How do you caption your videos and image descriptions? How do you make sure your website's accessible? I mean, that's something that you have to hire somebody to do, and it takes a lot of effort, but you don't know until you find out, basically. And there's some cultural norms, and I'm giving you this just as an example, but there's so many out there, and not every disabled person is the same. They're just things that, like, as a disabled person, I'm aware of, and I think it's helpful because then when I meet another disabled person, I can draw upon them. So for example, autistic community, autistic adults don't like to be called low high functioning often. They're really against ABA therapy in a lot of circles. They like to refer to themselves as neurodiverse. Autism Speaks is a really contentious issue with autistic folks because they don't consult autistic folks when they run their campaigns. There's a difference between capital D deaf and low D deaf and hard of hearing people. There's a lot of controversies around cochlear implants and whether or not, some deaf people don't think they're kind of like the deaf of their community. So that's good to know, right? Like, you don't want to meet a deaf person and be like, why don't you get a cochlear implant? Why wouldn't you do this? Integrated versus separate schooling, that's a often hot topic issue, and it's different for everyone, but like it's specific communities have norms around this. Some people refer to themselves as MAD because they resist the idea of mental health diagnoses. And like there's a lot of social activism around calling yourself a crip, which is reclaiming the word cripple. And how do you crip things? For example, like cripping therapy is a common thing, or cripping art, or cripping parenthood. I have a group called Cripping Parenthood that, tells us about like, how do we make something that's very traditional and make it more disability friendly and radical in some ways. But there's also attitudes. So I talk about therapists, but this could be any support person. There's one study I just want to point out that like 75% of therapists viewed disability as a personal tragedy, right? Rather than like something that needs to be navigated in an accessible world, it's viewed as something that's like sad and to be pitied. And I have a cartoon here just to kind of like throw that home, which is like, the assisted suicide clinic, I guess. I don't know that such a thing exists, obviously, but it has a ramp going up to it, but then there's like suicide prevention programs that are not accessible. So, you really want to be understanding where the problem of disability lie. You'll meet all types of disabled people, and some of them will ascribe to a more medical charity model, as we talked about, that, my body is the problem and I need to fix the chronic pain that I have, for example. Totally fine, but like also really important for you to get exposed to other views of disability that you're not familiar with, such as the human rights model. Disabled people are marginalized in our society. Disabled people have a really intense culture, right, of like arts and communities. And the social model, which is like disability is not located in the person, but rather in the society that's inaccessible. So I want to talk about disability-affirmative therapy, which was started by Dr. Rhoda Oken in 1999. It's less of a like to-do step and more of like an attitude that you bring to the table as a support person or a therapist. So it attempts to bridge those different models of therapy, both social and individual, and respects both the dynamic nature of disability as something that's changing. When I was a teenager, if someone came to me and said, there's nothing wrong with your body, you just need to live in a more accessible world. And I was 13 and I just been diagnosed with my disability, I would have been like, what are you talking about? Like, of course it's my body, I can't walk, right? So it's all about kind of like timing and changing and being able to change with that person. But, you know, you holding hope that they'll get to that place where like they don't always see their body as the problem is really powerful. How can you become a culturally competent disability therapist? And as I mentioned before, those disability norms we kind of talked about. How do you avoid assumptions? So when you see someone, how do you avoid deciding what it is that they're upset about before you even talk to them? And how do you include disability in your case conceptualization? We're not talking about ignoring disability and just seeing the person here. We're talking about integrating it and understanding it and not stereotyping it and seeing it as complicated. So this is like an overview of the model. So you can see all of these ways of seeing disability are integrated in the disability-affirmative model. Your client is the one that kind of decides which one do they kind of tend to, and then how do they make peace with that? How do they fit through that? But then you being able to like draw upon others can help them in ways that maybe they can't, or helps with you if you just are stuck in one model. You can really oppress someone, or you can contribute to their further marginalization if you're not paying attention to all these other ways that you can see your client. So this is just a one line about the disability-affirmative therapy, in that disability itself is not inherently pathological or deviant, and in fact has value and worth. So a client's disability should not be taken as information enhancing your understanding of the person in a way that neither underestimates nor overinflates the importance of disability. It's a very delicate balancing act. And you know, it's gonna look different. So 13-year-old me would have been like, disability is not important at all, I don't even want to talk about it. And you know, now me as a 35-year-old woman, like, yeah, it's really important. These are things that you might want to integrate into your care if you do get to see a person ongoing. So these are all things that can impact the trauma that a person has been exposed to as a disabled person. So is their disability visible? Did they have it early or late onset? Have they experienced discrimination and bullying, and to what degree? How much have they been exposed to other disabled people and disability culture? Socioeconomic status, like how much privilege you have and money you have actually makes it easier to be disabled, and unfortunately, because not everything is paid for in our society. How much access do they have to caregiving support if needed? You know, it's not all disabled people need it either. What's their own view of disability? How do they see themselves? Medical model, human rights model, you know, spiritual. Do they need any help with advocacy skills and medical decision-making? For a lot of disabled people, that was taken away from them. What's their experience with medical trauma? Do they have any romantic sexual history? And I bring this up only because a lot of disabled people are actually taken out of traditional sex ed classes, and that's really unfortunate. And sometimes their doctors don't see them as sexual beings, so they don't talk to them about sex. So they might not have ever had a pap smear or talked about birth control or safe sex practices. Not all of them, again, you don't want to be making assumptions, but it's just important for you to know that. And finally, is there any history of abuse? I'm going to skip this because I realize we're out of time. And I already mentioned this, that we want to rethink inaccessibility as and ableism as traumatic. And this is one of my last slides, which is like, you know, maybe we could rethink our models of care. So the independent living movement, which talks about, you know, nothing about us without us, which I think all institutions should have this sort of motto, is like, you don't want to be designing programs for disabled people without them involved. It's like coming away from the idea of caregiving and homemaking towards like support, aid, assistance, and models of interdependence. So this is a book that I recommend to everybody by Leah Lakshmi on care work and imagining disability justice differently. And these are some resources I've included in my slides. It's not an exhaustive list. Some of the ones that I've had really good luck with, so I wanted to include them. Oops, sorry. 1 second. Yes, thank you. And there's a couple of trauma-informed care for disability things available free on the internet, which is great, and I recommend reading them. That book about disability-affirmative care is right here, Rhoda Oken, What Psychotherapists Should Know About Disability. It's a great starter piece. The Ultimate Guide of Sex and Disability is good because, as I mentioned, about the sexual history of disabled people being marginalized. And thank you very much. And I know that I went through a lot of information very quickly, so I hope that there's questions.
Thanks, Kaylee. There are questions, and I really appreciate you winding this part of the presentation down so that you have a chance to respond to some of the questions that have come in. Quite a few people commented on the use of language, as did you, Kaylee, early in your presentation. And I wanted to start there. And a couple things. The first is about the term differently abled. And just to hear you respond to that term and whether it's generally preferred compared or relative to disabled. If you could start by just speaking to that.
So my experience with the term differently abled has been mostly that it's something that non-disabled people prefer to use because they that was my, like, sometimes I've been corrected by people and saying like, no, like, you're not disabled, you're differently abled. And it's like, no, disabled. Like, my impression with at least the community that I is with is that is not preferred, and it's actually can sometimes be seen as patronizing. That being said, there are disabled people that do prefer it. So I don't want to speak for all of them. I'm just speaking for, the people that I know and the people that have said that to me. I often get a lot of groans and head rolling when, eye rolling when that term is used from my clients or myself or from friends of mine or other community groups that I'm with. So I think that I wouldn't use it first. That's what I would say. If someone uses it themselves, then like, yeah, you listen to what people are saying and, kind of like respect their a way of identifying, because that's the most important thing, right? With autonomy is like being able to listen and respond appropriately.
So you're raising two really, it seems to me, key things. One is just that powerful reminder, in case any of us forget, that there's not it is a heterogeneous community. It's
Exactly.
communities. Yeah. And so because that raises another question that came in. Is there a preference? Have the communities come together and said, this is what we prefer? But I think you've already suggested the answer, but do you just want to speak a little bit to that? Because the idea was, is it about those of us who aren't part of the disability community or communities? Are we labeling, and is there a term that is preferred by people who are living with a disability?
I think that, like, I don't think there is a term. I think that, like, there's cues that you can draw. So if my experience again has been, if someone is newer to the community, or they just acquired their disability, they tend to prefer person first language. Like I remember being younger and I would be upset if someone called me. I didn't see myself as disabled, so I would be upset about that. But we don't, like, I just saw something come up in the chat box, which is very true. It's like, maybe we don't need one term, right? Like that's part of the beauty of the disability community, is that there is no one community and we don't all speak for one another. But that's just been my experience, is that, you know, people, if they come to you and they say, I'm really active as a disability activist, they probably will use identity first, but that's not, you know, necessarily true all the time either.
Thank you for that. I think the part that I'm really going to take away from that is listen, and the term that an individual uses, or the identity description, how whatever that is, then that is our cue. And I thank you for that.
And I think that's a good point too, is that you don't want to be the person that says, like, don't call yourself that.
Yeah. Kaylee, there was a lot of other questions that really loaded on in a global way inequity. And for instance, one of the questions relates to the long wait most times to access transportation, and then the attempting to use transportation if in addition an individual has a sightseeing dog, for instance. And the question is, and it's really broad, but I'm hoping you can grasp it and respond, but how do we respond and support to different communities with different needs in an equitable way?
Are you talking specifically about transportation?
Yes, I think the person who asked the question was.
It's a big question. I think.
Yeah.
I mean, my first instinct is to just really understand the system so that you can be understanding when somebody, you know, needs accommodations, needs flexibility that maybe you wouldn't normally provide, just because of the way systems are set up. Another aspect is, like, how do you promote change, right, in your community around this issue? And like there's systems in place that help people. I mean, we talk about systems as a negative thing, but there's also systems that support people to make changes, such as, like, I'm thinking of, like, the TTC specifically, because that's most of my experience, where the AODA is rolling out, and that's the Accessibility for Ontarians with Disabilities Act. And it's really impacted the TTC in that, like, all the buses are accessible now with ramps, and they have, what's the word? They announce all the stops, whereas they didn't do that before. And that was because of an advocate saying, you have to do this. And, like, David Leposki going forward and you know, I think he's a lawyer, so I think he might have sued them. But through that, he created systems so that disabled people can come together once a year and attend a large forum and talk about, like, all the issues that they're having with their transportation. So that's an example of, like, even if you feel like, oh, this isn't going to change, like, you're still there's a spot with a bunch of disabled people together. I think I saw a comment there that was like, where is this disability community? Where do they meet? Which is true. Like, we don't have a physical location. We don't just, like, meet in random places. So, like, having things like that is so important, because you get to have that sense of community, meet other people, organize, talk about what you could do. So, because I think, like, trying to do it on your own is quite disheartening a lot of the times. Being your advocate for your client, so saying, like, if they're saying, like, I can only get it at this time, this bus at this time, trying to, like, work with them and see if there's other options that you can get. Trying to make sure they have, like I used to work with teenagers who, because of mental health issues, couldn't take regular transportation. And often I had to advocate for them to get onto different types of specialized transportation that wasn't kind of like the more public domain, so that they could access the treatment they needed.
Right. Thank you, Kaylee. And you're right, it was a very broad question, but I appreciate where you went with that. Kaylee, another question is inviting you to elaborate a bit more on, quote, cripping therapy. What is it, and more, a little bit more about its impact on the disabled community?
So the term CRIP was like was presented, I guess, more in the disability scholarly work around like, how do we take a system that's very traditional and kind of like put it on its head and, you know, challenge all the assumptions and norms in it to try to make it work for folks that don't kind of fit into those models of who it was designed for in the first place. So as an example, with therapy, cripping therapy might mean, well, can you have different ways that you meet with a person, not just in an office one-on-one? Like maybe the person needs a support person to come. I'm losing my voice now. A support person to come to therapy with them. And usually therapists would be like, no, that's going to ruin the therapeutic alliance. You're not going to get into things as deeply. But from a cripping therapy perspective, you'd be like, well, what's in the best interest of the person getting the support they need? And why do we have this assumption in the first place? Does it work for everyone? You could do kind of like research in this area. It's very fascinating, but like, I'm trying to think of, most recently I read one on cripping care and how like we needed to think of new ways to define care, not just like a caregiver, active agent providing support for one passive person, but rather like, why did caregiver burnout exist, right? It's not because the disabled person is entirely burdensome, but rather like the caregiver might not be supported by systems either. And like, what do they get out of this? Like, it's not just a one-off. The person who's getting support also offers things to the caregiver and vice versa. There's like an interdependence that goes on. So I think if you just want to think about it, it's just like, how do you flip something on its head, take away the norms, and try to make it work for disabled or different folks?
I think that helped. That's a lot clearer. Yeah, thank you. A couple more specific questions, Kaylee. Do you know of any guidelines or guides, brochures, pamphlets for PSWs, personal support workers, working with survivors of sexual assault? So individuals with a disability who have experienced sexual assault.
It's a really good idea, and I don't. But I've often been on the other end of things where I'm trying to educate either as a psychologist or as a consumer PSW. So I think that would be quite useful, and I haven't found anything, but if anyone knows anything.
Thank you, and we'll look too.
Yeah, it's needed for sure.
Okay, so I'm taking a note of the individual's name, and we'll look, and if we find something, we'll run it by Kaylee and some others that we've worked with and post it on our website if that's helpful to everybody that's on this webinar. Another question, Kaylee, you've been talking about accessibility and the challenges given our current transportation system, given ableism as it exists within our society, within us. And then on top of that, we're living in a pandemic. And we have a lockdown in many areas of the province, that the measures have even become more restrictive because of the concerns of people's health and the contagion in terms of this pandemic, this COVID-19. And then on top of that, Kaylee, we know that we're really concerned about people experiencing violence, intimate partner violence, other forms of violence that occur within homes, and especially when people are becoming more and more tied to their homes. And so when we put these two together and then think of individuals that already may be more tied to their homes, and may not just be facing potential abuse from an intimate partner, but also from a caregiver, if that caregiver is different than an intimate partner. Can you speak to that, and any just your any understanding or anything you'd like to share, and especially any suggestions around support or things that people on this call may do to reach out and support?
Yeah. I think that's a really complicated question, and I don't have any kind of like easy solutions, of course, and it's very complicated. Like, I know I'm just sort of like, as you were talking, I'm struck by like someone in a community I'm a part of, like on a Facebook group, was experiencing this very thing where, they couldn't get their nurses in because of COVID, and they couldn't figure out, their family couldn't help them. And unfortunately the person ended up committing suicide. And I just like really struck by like how hard this is for everyone, because there's not the same options that there usually is around, and there's already limited options. So I think that one thing I want to say is that working with my clients is that sometimes there's internalized ableism that also prevents them from reaching out too. So they might be living with someone, or they might be living alone, experiencing a really hard time with the caregivers, or PSWs that come in to their home, and they might be getting increasingly more limited, increasingly less support. And then when I talk to them about like, can we reach out to your brother? Can we reach out to your cousin on your mom's side who's really supportive? They're like, no, I don't want to burden them. And I think that that is important, because I get it on one hand, and on the other hand, it's like, but you deserve care and support too. And we need to figure out something for you, right? Like, we can't let you sit here, and there are other options. Sometimes there's other family options that the person's not considering. So I think that just being like a gentle kind of exploring, why not, what's the getting in the way? And sometimes they're right. And sometimes, it is worth kind of exploring a bit more. There are other services out there. If their one care provider isn't helping, there are options for, perhaps advocating for them to get direct funding, for example, getting some temporary support or funding so they can hire their own people, getting support around contacting like shelters and seeing like who's taking people in, who's not. I think that there are options. It just feels very dense in some ways, and you have to do a lot of legwork and a lot of advocating and a lot of pushing against these systems to say like, this person needs help now, right? We can't wait. So that would be my two suggestions.
Okay. One of the things that was brought up, Kaylee, is that just this desire to avoid tokenism, and yet the recognition at the same time that agencies may hire individuals with disability to help improve their agency. However, it may come across as tokenism. And just wondering if you can comment on that, or have any thoughts that might be helpful to the participant who raised that comment, observation, concern.
I have a lot of feelings around that too, because I feel like it's complicated, because as a disabled person, you often feel disadvantaged, and then you get a job and then people are like, oh, they only got it because they're disabled. And it's like really frustrating, because it feels like you're damned if you do and you're damned if you don't. So from the perspective of the person looking for the job, I would be on the fence around like trying not to be so worried about the tokenism, because like if you are like worried about it, then maybe they'll internalize that and be like, oh, I didn't deserve this job. And like, why is one of the things I learned through my years is like, how do you use disability as a strength in understanding the world from a different perspective? For example, if I knew that the Toronto Psychology Clinic hired me because they wanted a disabled therapist because they have a lot of disabled clients who are looking for that, then that's something that like I would be proud to take on, right? Because like someone is looking for my identity specifically because they think it will strengthen their organization. And I feel like a lot of organizations could benefit from a disabled person who knows the world a little bit differently, can access community supports differently, and brings just a new perspective to the organization overall. So my preference would be to like lean away from the idea of tokenism and more towards like strength-based, like what does this person bring to the table that other people wouldn't?
Okay, thank you for that, Kaylee. Kaylee, there have been a number of comments sprinkled through the chat box throughout the webinar and also in the Q&A about, for some individuals, and we apologize, and we're learning too as a learning network and knowledge hub that this was not an accessible experience for some individuals who wanted to participate. And I just want to say, not as an excuse, but for future, we are working hard on increasing the number of opportunities for sharing and information sharing that do have ASL interpreters as part of that, and also looking for closed captioning. And what that means is also looking for funding to ensure that that occurs. But I do recognize, wanted to recognize the comments. We're not ignoring you. And just to share on behalf of the team and myself that we are on a learning journey and trying to do much better at that. And I appreciate people sharing that feedback, which we truly will take to heart. And our planning and in our looking at funding as we go forward as well. And our apologies to you, Kaylee, that it wasn't as accessible. And I know that obviously that would have been very, and is very important to you. So I wanted to state that. I also wanted to thank everybody. We had an amazing response to this webinar with you, Kaylee. And not only did a lot of people register, but a lot of people actually participated in the webinar. We had close to 550 at the peak of participation. And I think it says how important this area is. And just even your polling, Kaylee, and the responses, the field, we've made some progress, it sounds like, from what you're saying and your own experiences, but we've got a lot further to go, and the Learning Network and Knowledge Hub are living proof of that. And I know that we will be looking at bringing more speakers and more people to share information on this topic. And we thank you, Kaylee, for doing that, for being with us, Dr. Rosen, and for sharing your expertise and your personal experience as well.
Thank you.
It's been very valued.
Thanks for having me. And I'm glad to hear that, I remember when I was preparing thinking like, oh God, is this captioned? Is this gonna, so I'm glad that like people are speaking up and that we'll be able to do that.
Yes, and I am too. Thanks, Kaylee. To everyone, we will sign off now. Don't forget the link in the chat box takes you to the evaluation. Complete the evaluation, and that generates your certificate of participation. And also just a reminder that the responses on the evaluation are not linked to your identity on the participation certificate. So the evaluation is completely anonymous, and we just want to remind people of that. And thank you for the activity on the chat box and for the amount of sharing that people did. I was trying to keep track of that while listening to Kaylee, and also looking at the Q&A, and it was really really active and vibrant, Kaylee. We'll try to capture that so that you can experience it as well after the fact, because I know it's almost impossible to follow the chat box and present. But we'll try to get a copy of that for you, so that you'll have that and be able to see some of the sharing that people did.
Thank you.
Okay, so be safe, everybody. Take care of one another, and hopefully we'll see you soon at another webinar. Bye for now.
Bye.